PPIs totally disrupt your gut flora, which means that these poor little babies, you're on something that, one, it's super hard to come off. It's really hard to wean off PPIs.
Welcome to the Less Stressed Life podcast. This is your host, Krista Bigler, private practice integrative nutritionist, helping people across the U.S. reverse digestive issues, eczema, and autoimmunity via phone and video consult. To learn more, visit lessstressednutrition.com. Now, on to the show. Okay, today on The Less Stressed Life, we have Dr. Valerie Jacobs, who holds a degree in medicine and a Ph.D. in pharmacology with an emphasis in neurology and immunology from Dartmouth College. She completed her residency with Harvard Medical School at Boston Children's Hospital while working in the emergency department. She's a board-certified physician and a member of the Integrative Medicine section of the American Board of Pediatrics with advanced training in Reiki and Medical Acupuncture. She currently works in pediatrics private practice with a focus using a holistic integrative approach, and she believes in partnering with families and investigating all the aspects of the patient's life, creating a whole health approach to understanding medicine and a safe, effective, complementary treatment for patients. Welcome, Dr. Jacob.
Thanks, Chris. Thanks for having me.
Yeah, so I think it's kind of fun. People actually ask me a lot, how do you find guests? And I say, all over the place. Sometimes people request, sometimes I go to a conference and I say, I would love to talk to that person, or I meet someone. And Valerie's email just landed in my inbox one day because she found the podcast. And she said, hey, you don't have a lot talking about pediatrics and digestive issues. And I'm like, I'm happy to discuss that because that's something that we see in practice, and I work with kids as well. So I'm happy to have that conversation. Love to have that conversation. A lot of smart, savvy moms listen to this podcast. So we're really excited that you want to talk to us about this.
Awesome. Well, thank you for having me.
Yeah. So let's talk about how you got to where you are a little bit, because I think when I was reading this was the bio I read, but I was reading a little bit more about you on your website, and it looked like maybe you did a little teaching before you kind of went to med school maybe. And then also I see you have other types of training. How does that happen? How do you decide that you're going to do this other training? How do you decide you're going to become integrative? What's the turning point there?
Yeah, it's a really good question. And I think, like many of us, it just kind of falls that way from either personal experience or patient experience. And my background is very basic. I have a Ph.D. in immunology, and it started on that track, really doing kind of the basic research. And from a patient perspective, I was mostly seeing early on in my training that, wow, kids and people are a lot more complicated than we think. And the immune system is way more complicated than we think. And we're doing all of these medications, and sometimes they work, but sometimes they're causing more trouble. And I felt like as a provider, sometimes you're just putting out fires. And really the reason we get into this and working with families and all of you out there is because we want to heal you. We want you to be your best self, and we want to get to the point where, not to use the cliche word, but the root cause of things. I wanted to get to a point where we're not putting out fires. And I think the way to do that, we really have to go back to our basics, which is our body, our inflammation, and nutrition. And I think we're getting there, but in traditional medicine, that's still not always part of the general assessment and workup. And so that's what made me start researching, okay, well, what are the clinical evidence and what is the protocols, and of course still using evidence-based medicine of going back and doing these type of approaches that are safe, that can be used with other medications, and that can really help children at the very beginning stages, and maybe even not get them to that point where we're constantly putting out fires. And then one thing led to another.
Yeah. And so you actually found some trainings that were already there for you. Yeah. It wasn't as hard to get into as maybe you thought.
No, not at all. And there are other amazing people, like doing research on this and making it part. And I noticed as I started applying this, even as early as my early days in the hospital, you get amazing results. Kids would do better, families were happier, and it was wonderful. And so I just started doing this more and more, and essentially it became really the foundation to my practice.
Mm-hmm. And now you're in private practice. So you were in the emergency department at Boston Children's, which gave you a great breadth of seeing all the things.
Mm-hmm.
And now you're in private practice seeing clients individually. And so, or in a better setting where it's not so like you can follow them a little bit longer term.
Exactly.
Mm-hmm. So, and getting to do what you love. So what are the things that present to your clinic most often? What are the most common things you see?
Yeah, so I see obviously sick kids, especially needs, and I also just do general primary care. But the top 3 or 4 things I see in general kids coming in: belly pain, right? It can be anything, behavioral issues, and then of course bowel habits. Constipation is a big one, and then when the little ones spit up, reflux or trouble with food and digestion in the infant. Those would be my big 4.
Mm-hmm. Pain, behavioral issues, bowel habits, and what would you call the last one?
I would say just spit up in babies. Like we call it reflux, but it's not always reflux, but that might be what they come in for.
Mm-hmm. Yeah. So let's talk about that a little bit. How common is the spit up or reflux, and at what point do you find it more troubling, where it's a little bit outside of like, oh, it's just a little bit of spit up?
Yeah, good question. So about 50% of all babies, these are kids under the age of 12, are going to have some kind of actual reflux. I usually tell them if they're a happy spit upper, they're growing and doing fine, it's not a problem at all, because at that age, part of it is your gut motility is just not even developed yet. They don't have a great sphincter. They don't have a great way to keep that food down. Everything's gravity at that age, and so food is coming up and down all the time, and totally common for it to come out of the mouth. When it becomes an issue is when it becomes upsetting for the infant. So if you're seeing a lot of fussiness, increased gassiness, trouble with bowel movements, certainly if you're spitting out so much that you're not digesting and you see changes in weight, that's pretty extreme when it gets to that point. But those are all reasons that I start targeting it.
Okay. What did you say the percentage was that you see that?
50%.
50%?
It's actually pretty high.
Okay. Yeah. Yeah. Pretty good chance. Just as much of a chance of having an issue than not. Okay. So you said gravity is a big piece. And sometimes I talk to people about, sometimes there's a structural piece or a nutritional type piece or an emotional piece. But I think about with reflux, do you go over structural interventions at that point? Like literally, do you go over, hey, like let's sit up after meals longer or something like that? Is that common?
Exactly, totally. So always you want to do like a minimal approach first, right? And yes, we always start with a basic, okay, usually we'll do a combination. So sit up at least 30 minutes after the feed. And then I also recommend splitting the feed. So make little breaks. So pause maybe twice in the feed, do a burp, and then let the infant eat again, and then keep upright for 30 minutes. And then in between, when you're practicing tummy time or playing with your infant, there's some basic, which I'm happy to give you two basic infant massage moves I teach too, to kind of help that bowel movement start going and get the gas moving. And that's where we start.
Mm-hmm. So that's where you start. And then are there some other things that you use? Like, what are some other interventions you may or may not use with someone with reflux? Like, do you go straight to, is it really common for someone to end up on reflux medications or PPIs? And what does that look like for kids?
Good question. I do think that historically that's a very common thing that pediatricians do, because especially if you have an association with fussiness, the thought is, it must be pain. Must be pain from all this acid. Okay, we're going to put them on a medication that stops that. First of all, to be really clear, it's not always the acid. You can have pain and discomfort, and the actual, for the kids that have been scoped, the actual kids that have true acidity issues is rare. So oftentimes they're using there's not even an acid problem. Secondly, as we unfortunately now know, right? Sometimes we use these for years and then we figure out, wasn't that great for you. PPIs totally disrupt your gut flora, which means that these poor little babies, you're on something that, one, it's super hard to come off. It's really hard to wean off PPIs. And two, you can change their gut flora, leading to increased things of like SIBO, small intestinal bowel overgrowth, which causes lots of problems. I see that in toddlers later in life, as well as other issues, which makes you prone to things like leaky gut, which makes you prone to things like pretty bad food allergies. So that all ties together. So as a rule of thumb, I never, and I think more and more practitioners are hopefully going this way, I never use the PPI. There's so many things we can do before that. For example, often I look at, okay, digestion, what is actually causing the reflux? Are we having reflux because things aren't moving as far down as they need to, or things kind of get stuck, or things going slow? Do we need to work on the motility of the food going through? Or are you getting a lot of gas production or reaction because you're having a reaction to something in the food? And in that case, I often will do food elimination with mom if they're breastfeeding, or try experimenting with different formulas if they're on formulas. And my success rate has been pretty high doing those simple interventions and never needing to go to a PPI.
Mm-hmm. I was doing a lot of research recently for I was writing about eczema, and I was surprised at the number of if you change to a hydrolyzed or basically a pre-digested formula, that can clear eczema very quickly in a lot of kids. Like, it was a very, very high percentage. And I'm sure you see the exact same thing, because really, if you're not able to digest things perfectly because things are a little immature or whatnot, adding a PPI or reducing the stomach acid, which helps break down things, which can help break down proteins, isn't going to help if that's the root cause problem. Do you give enzymes in children at all? So hydrolyzed formula makes sense because then it's already kind of like already pre-done. But do you ever give enzymes to kids, or do you kind of try to avoid that as well?
So really good question, and I do. I have one little infant who's 2 now, who we've been working on some inflammation and some essentially really bad gut gas that she's had really since she was 6 months of age, after getting tons of rounds of amoxicillin from another pediatrician with repeat ear infections. Unfortunately, kind of messed up her gut, and then she started getting eczema, and then she started getting other issues. And so we did food elimination, which worked pretty well. And then when they're that young, I don't treat kind of bacterial overgrowth or gut flora abnormalities with antibiotics, but I can avoid it when they're infants. And so we do a lot of prebiotics, we do a lot of food allergies, but in this infant, she was still having a lot of really bad gas. And really, I think what it was coming down to is she was still having trouble digesting, and she was old enough that we couldn't obviously do a different formula. She was starting to eat food, and so we did end up doing some digestive enzymes with her, and it worked beautifully. And it did end up really helping get that gas under control and the pain better.
That sounds like a classic story I hear all the time. We have to go on antibiotics for XYZ thing. They're a good life-saving thing, but they can be, I mean, they can really damage what's going on in the gut microbiome. And then I always say we're growing weeds in the microbiome, sort of when you're talking about small intestinal bacteria overgrowth, or, we didn't talk about large intestinal bacteria overgrowth. That's a thing I see a lot. So we've got a lot of weeds growing. And so how do we pluck the weeds, rebalance the weeds, make it so there's a very nice lawn? Because if there's weeds going on, it's going to impair digestive ability. And so that is so common, and it presents as eczema all the time, right? Which is the condition that I see all the time. So we definitely see an association. Something we were talking about off air was, and I'm really hoping, so not too long ago, I had a mom call me, and her daughter had a lot of fatigue. She's a teenager, a lot of fatigue, ferritin or iron levels were extremely low, to the point this girl is not getting out of bed. So anyway, after talking to mom, I'm like, that doesn't just usually happen. So what was going on in the gut, or, are we having heavy bleeding menstrually or something else? So anyway, come to find out that this girl who was not so little anymore, she's a teenager now, she's been on an acid reflux med since she was a child, and just left on it forever. And I'm like, oh my gosh. So we now know that there's a lot of downstream effects, because at the very top, we're not going to be doing things properly anymore. So once it's a little
Absolutely.
bit, once you mess with the top of the funnel, then there's all kinds of things that can happen downstream. So we were talking a little bit off air about a study that came out in 2018 in JAMA. So big deal, of almost 800,000 kids that were on TRICARE. So they were on, they basically just looked at data as to, okay, so if these kids were on a PPI, which is a reflux med, or an antibiotic in the first 6 months of life, which, I mean, those first couple of years are kind of important for the microbiome. If they're on that in the first 6 months, first 6 months of life, the percentage or the likelihood of allergic diseases later on is really significant. What do you think is going on there?
Good question. I think this is huge because I think exactly what you're seeing, how we handle things later on in life is so affected to how we kind of train our gut and what we do early on in life. And so my theory is really good. Again, not a lot, there's not as much data in the little kids. This is why this study was so important, but we can extrapolate a little bit of the data that's in adults. So we do know that PPIs, beyond obviously changing the acidity, completely change the bacteria, good and bad, in your digestive system. So it leads to increased risk of getting things like SIBO. This has all been shown in adults. We also have pretty good studies that say it also affects just that really important tight junctions. We want our bowels to be like a good cage, right? We only want to let in things that we need, and we want to keep everything else out that we don't want in. And unfortunately, with breakdown, and PBIs can do this, that gate gets a little laxed. It starts being open when it shouldn't, and you start absorbing things you shouldn't, which are antigens, inflammatory cell, all things that lead to you having an inflamed reaction to things you shouldn't, and ultimately can lead to allergies because you're starting to be exposed to things regularly in a way that you normally shouldn't with your body, and have huge reactions, and then there you go, and then you start having allergies.
So I do want to talk about allergies and how that's tested because this is a big discussion topic with eczema kids. But I have a question before we get to that point. And your focus is pediatrics, and so you're seeing the kids. But do you ever ask questions about the parents and their digestive health? So it makes sense if the kids' stuff started after a round of antibiotics, right? Then we have a quick, clear, maybe starting point. But if it just started randomly, or if it's always been like this or whatnot, how is the parents' health implicated? And I've paid attention a lot to what's going on in research on, okay, can we see that they were transmitting this microbiome? I mean, so what are you seeing in practice?
Yeah, I think there's a little bit of data on that. We don't have a lot, but certainly we know that early on when you're born and your mom, especially if you have a vaginal birth, that is a really important step in terms of developing your microbiome and giving you that good immune defense. However, what I've noticed more is, and I think there's a little bit of how your body responds to your environment. There is a little bit of that's genetic, right? And so certainly I always ask, hey, have you noticed you are upset or have issues with food allergy? Do you notice you get bloating? Have you had asthma at some point? Did you ever have eczema at some point? Do you get rashes sometimes? And some of that is because, okay, maybe these people are sharing the same environment, right? Kind of what you cook for yourself, your kid is also getting. And then some of it, too, is a little bit of genetic. Like I always tell people, you can have a, bad salad at your family picnic and everyone will eat it, but not everyone will get sick. Some will be really ill. Some will act as if nothing happened. And some people might have, a little bit of an upset stomach. And that all varies based on kind of your predisposition, how you're going to respond to that. So I do think a little bit of that is also genetic because that definitely trickles down.
Yeah, definitely. Or what's the current environment of the microbiome, right? Because if you already have a lot of weeds and we add a bunch more with a little bit of food poisoning, those people may not recover as quickly. So many things there.
Good point.
So when we're talking about allergies, are you seeing an increase in actual food allergies? And to tie into that also, a common discussion point I see with kiddos with eczema is that sometimes a doctor will test for food allergies at a young age and sometimes they will not. So tell me what goes into those decisions.
Yeah, I always start with, so to me still ultimately, which is what you end up doing anyways, ultimately the gold standard, right, is still an elimination diet. That's really where you're going to see if you get a benefit. So for the younger kids, and actually really I even do this with the older kids, I tend to start there just because maybe we'll get lucky, gives you an answer right away, gives the family a tool to start working on. And then if we're still having trouble, I move to food allergies testing. So food allergy testing, I will do, my rule of thumb is in terms of the immune system after the age of 2, it's pretty much been developed. So anytime after that, I trust the data. If I'm doing a food allergy test before that, I tell the family the caveat is this can change. We can work on it, it can get better. It can change over time. They might develop completely different allergies, and this testing might be completely different in the next 6 months because, exactly like you mentioned earlier, you're still really growing that gut flora and that microbiome. But in general, I always start with food elimination, and then I am seeing it way more, but I also think it's because I'm learning to look for it more too. Because as I'm sure you've experienced too with your clients and patients, people don't present all the same way, right? With food allergies or food intolerance. Like, yes, sometimes it's eczema, but sometimes it's not. Sometimes it's poor growth. Sometimes it's behavioral issues, focus issues, and you look and notice that there's issues in their stool, and you narrow it down. They're having certain responses with things they eat, and so I don't always think it's so easy to find. So I actually always start with a very detailed diet analysis and food analysis with all my patients, regardless of their symptoms.
Cool. That deserves a round of applause from this dietitian. So that's cool. I like how you said it, because I had been hearing kind of 3 years old, and I think it doesn't matter if it's 2 or 3. This is around the time that the microbiome starts becoming really established, right, for the rest of the life.
Exactly.
So it's interesting that we also see that at this point, that's when we think that food allergy testing is maybe a bit more accurate, right?
Accurate. And it's also interesting because that's when, from a pediatric standpoint, that's when we officially can start diagnosing things like asthma and stuff. We really don't even consider, you're not allowed to diagnose until after that age anyways, because all those things play such a role, and kids having wheezing earlier on might completely dissipate by the age of 2.
Okay. So let's talk about the appropriate ways to test for food allergies, because I get to talk to the aftermath, and it's all over the place. Some people are doing blood testing, and some people are doing skin prick testing. And I know what I've seen in my research, but I trust you and your gold standard. So what should people be doing for different things?
So I think it much depends on what you're specifically testing for and looking at. Some specific things do better in a skin versus a blood. In general, I test blood because I actually want to look at both IgE and non-IgE, right? Like the National Institute of Allergy and Infectious Disease says food can actually be 2 types of allergies. You can have the IgE mediated, and you can have a non-IgE, and they can present in very similar, very different ways, and that alters kind of how I treat and work with the family. So I do blood because I like to see both of those, and that helps me kind of design what we're going to do and move forward.
So do you know if this is right or wrong? When I had done research about this a while back, it was thought that blood was better for food for sure, and skin may be better for environment. Is that accurate, not accurate? Not sure.
Good question. I think you can make that you can make that generalization. Certainly some of the environment will still show up in food. The thought is the environment is going to be really triggering more of like that histamine reaction in your allergies, which is really that basis of that kind of redness you get when you prick somebody on their skin for the skin test. And that's why you're getting that. And when you're looking at the blood work, you're really looking at a more longer formed memory response to whatever the trigger is you're testing. And so it's a slightly different mechanism really that you're testing for. So so skin, redness, histamine, definitely that's what triggers our environment, makes our eyes water too, and makes us sneeze. And then the blood will test for things too that are more, takes longer for immune response, that might trigger things such as like pretty bad long-term belly aches or that fogginess you get in your head. But So I think in general, I tend to do the blood work because of that.
Mm-hmm. So I want to talk about IgE versus non-IgE because IgE is well recognized. This is what we use. This is what allergists use. So IgE as an elephant. And so that's what we think is reproducible. We can see that again and again. Like in theory, if you would do the same test over and over a year apart, you should get the same results technically as the thought process to my understanding. That's how we always talk about it. But then non-IgE is all the other mechanisms technically. I call this sensitivities. Yeah. I think this changes based on what's going on in the immune system. What do you think?
100%. And that's ultimately the goal, right? That's the goal is I tell my families, especially when you get it back, you're like, my goodness, there's maybe 6 foods on here. The goal is to get to a point to heal your gut, to turn these off, but not like a extreme IgE peanut allergy. We're not making you eliminate these for life. This is just kind of exactly like you said. This is telling us a little bit about how your gut is working right now and how your body is working. And our ultimate goal is to fix that and heal that so some of these things can be added back.
Yeah. So when people are looking at their allergy test results, so actually their IgE test results, to just be kind of standardized here, what's the range on the scale that they're looking at? And sometimes there's surprises like, oh, I'm only 0.34 to this. So do I avoid it? Do I not avoid it? I don't notice symptoms. How do you handle that?
Yeah. Ultimately, this is where it comes like into your individuality. So yes, so the ranges on the testing can all be a little different, but it definitely can be small changes from even just a half a point. And depending on the test, oftentimes it's 1 to almost 4. I tell people even if it's that small change, in general, anything from around 1, I don't worry about too much. For the small changes, I say let's try it. Try taking it out for a week or 2 and see how you do. Because the ultimate answer is always you and the individual and how you respond. And so for some people, that small changes, even on the skin, might be big changes in the body. So I tend to try it. And then if you don't see anything, it's okay. You can add it back in. It's going back to the whole elimination diet as always the gold standard.
I think that success markers in kids include mood and sleep, and I'm pretty sure you feel the same. So do you see that shift a lot, or do you have any stories about how that has, how parents have been surprised that when food changes, mood changes?
Mood is huge. Mood. You're right. But yes, I have a 9-year-old female. She was kind of an extreme case, had some behavioral issues to the point that she was actually briefly in the children's hospital for a week on many medications to calm her down. And she came to me, also had extremely, extremely bad seasonal allergies. She kind of had the whole bucket. And slowly, very slowly, with doing different general allergy treatments, weaned her off all of her, I think she was on 4 antipsychotics. I've been working with her over a year now, and we have just finally completely eliminated gluten, and she is off all of her medication. She still has a little bit of allergies that come through that affect her behavior, but very mild. It's now completely controlled by just behavioral interventions when she gets upset with those small allergies. But in general, she's an extreme case, but I like to tell the extreme cases so people know that like all the range can happen. So this is a kid that was literally on 4 antipsychotics and had extreme allergy to gluten and some dairy, and when those were taken out, completely different child, and is doing really well in school.
Yeah, it's a good story to tell because, I mean, kids shouldn't have to be, they just deserve better, right? They deserve for us to do better for them. And I mean, that's some people might consider that to be an awful intervention. The audience to this show doesn't find that to be they find that to be, that's an acceptable intervention. And so it's a great story, because, and it's, I mean, it makes us sad that she had to live till 9 years to see that. Right. But I see that a lot with even my eggs and my kids. I've had some interesting things where like kids will get into certain things and their mood is crazy. I had a kiddo and then I ended up helping his grandmother with issues as well. And I remember her saying to me, I have my grandson back. Like he is just a better, happier child now because of correcting what was going on in his gut microbiome that ultimately affected how he tolerated foods. Soul chicken and the egg situation. So you were talking about bad seasonal allergies. We could talk about histamine and immune insult, but I think something I sometimes hear is people say, I had this allergy testing done and I feel like I hear all these people. They're like, the doctor says, oh, I've never seen anything like it. You're allergic to everything. Or they just are, they react to everything. What's your opinion there? You think the immune system is just kind of totally inflamed?
Yes, I definitely do. I think when you're one of those kids, and I've seen it too, where you're just literally turning positive across the board, I tell people that is way too hard to kind of dig in. I don't think you're allergic to every food. What I do think is happening is you're so inflamed. It's almost the way you think of what happens with an autoimmune disease, right? Your body gets angry at something and it essentially overreacts and starts responding to things it really shouldn't or normally doesn't. And so that is a huge ding, red flag to say, okay, we got to calm this down first. And those are the kids that, you start doing just really basic calming, go back to your bone broth diets and look at the environment and really just say, okay, we need to calm this inflammation down and then maybe consider retesting.
Yeah. Because we don't think that those test results are necessarily accurate, right? We assume that there's no way you can be completely allergic to everything. No way. Yeah, definitely.
Yes, I totally agree.
So let's talk about growing out of food allergies. What does that look like and how common is it? I know it depends for the type of food.
It definitely depends on the type of food. In general, the data says that for kids and with IgE-mediated kind of bad food allergies, it's about 20%. Those are the kids that we think about with, that might have like an anaphylaxis reaction, maybe the kind that gets you in the hospital when they eat a food. That's about 20%. The data on other or maybe food intolerance, if you want to categorize that, is much, much stronger and higher because part of that is like I said, you're healing how your body is responding to the food. So you're much more likely to actually be able to reintroduce foods when it's not an extreme allergy like that.
Something I tell clients a lot is that, IgE is really well recognized, right? I mean, we can practitioners agree about this. Not all practitioners agree about food intolerance and non-IgE mediated stuff. Would you agree with that still? Are we even the people to ask? Are we turning a corner? Because once you start surrounding yourself with people that have already turned the corner and are doing new things, and then you see people that are still kind of, working in 1995, it's, you don't know what's most common. So what do you think is happening? I mean, do you think we're starting to accept this more and more?
I think so. I actually do think so. I still definitely, have some colleagues or some kids who will see their immunologist who will say, oh, no, it can't be that. If you don't have an anaphylaxis reaction, it's not a food allergy. But then at the same time, I absolutely have colleagues and immunologists and allergists who are starting to do this themselves. So, we're not there yet, but we're getting there. And I think you can't argue with, exactly like you said, which happened with your patients. You can't argue when you see that amazing difference in a child with these type of simple, safe interventions.
Yeah. I think one of the things we want to make sure we talk about today, because you mentioned eliminating things a couple times. So it is definitely our thought process for sure. When we have a significant allergy, the treatment is avoidance. With other things, it might be a short-term avoidance, but as you mentioned earlier, we're trying to heal things. Since we're dealing with kids, and I think it depends. I think it's easier when you're 2 or 3 and you don't know the difference, if possible. it's different as we get older, right? As with teenagers, how do we broach this topic? One, with parents, so we're talking about this in a healthy way, because our goal is not elimination long-term for a lot of things, right? We want to have the broadest diet. We want to have as many colors as possible. We don't want to be limited. And I do get the other end of the spectrum where people are like, oh, I started limiting and now I'm in this limited box, and they don't know how to get out of it. I'm not sure if you see that, and what are some steps you take to make sure that good food relationship is being considered and parents are like speaking positively about food, etc.? Or is that something you counsel on?
That's a really good question. And I think this is where, the saying, it takes a village comes into play. So early on, we talk about it that, this is just part of healing. And when I talk about elimination diets, I really focus on this is short term to give us a way to find tools. But then I actually tend to work, not always, but often, with a integrative or functional nutritionist or dietitian too, with my families too, to kind of go through too and say, okay, let's look at what's healthy. Because everything has to be positive, and we want to think not in the, exactly like you said, early on we talk about elimination, but big picture, we don't want to think of taking away, right? We want to think of bringing good things, right? So early on for the preventative care, before I have a kid coming in with an issue, and I'm just doing regular primary care visits, we spend a lot of time going around, okay, what is good food? What do we want to include? What is this bringing to us? Like, why is this fat helping their brain? What is this vitamin A doing for their body? So that early on, we're always thinking positively and how all these foods can positively affect our bodies.
I love it. If you could leave people with one kind of gut reaction on here's something you can do today to improve your children's health or whatnot, what would you leave them with?
I think my biggest thing that I'm trying to work on, which is hard in teenagers, is breakfast really is the most important meal. And if you can do a low glycemic breakfast index for your kids, it will be a huge difference in their focus and their outcomes throughout that day. There's really good data that even that simple change affects test scores. So my number one take home for all my families is try to get that good protein, non-sugary, healthy fat breakfast in before they're out the door. Makes a big difference. What
are your favorite, what people want to know is what you're feeding your kids for that then, because they want some ideas. So tell us what's common in your house.
Oh, I'm a huge avocado person. So I am also a realist, and we're all running out the door, right? So I understand too, I am not creating these amazing breakfasts at 4:00 in the morning. So we do a lot of smashed avocado with a little bit of spices on top, or eggs out the door. Sometimes if we're really creative and have time to make our own kind of healthy granola bars over the weekend, we'll do that. But that is my go-to breakfast. It's easy. I don't have to think about it, and everybody loves it.
That's what I had for breakfast an hour ago.
Okay. Perfect.
Yeah. Dr. Jacobs, where can people find you online?
Yeah, so you can, I'm at EasyKidsMD. That's my handle. I tell people it's easiest if you ever want to follow me on Instagram just for quick tips or things, and then I also update there. But on my website, I also keep a blog. And also, people are always welcome to reach out to me, reach out to my staff if they need help with guidance or looking for different nutrition or supplement questions. Feel free to reach out. I'm happy to help in any way I can.
Yeah. So I'm going to reiterate. It's AZ, like Arizona Kids MD.
Yeah.
So AZ
like Arizona, or A to Z.
Yes. There you go.
A and then Z, but yeah. Exactly.
Okay. Cool. I love that. And that will definitely be in the show notes. I actually looked at Dr. Jacobs' blog last night or this morning, and it's great. You should definitely go check it out. So that's not always a recommendation. I have to give it this way. I'm like, there's lots of good stuff here. Questions I hear all the time. So definitely go check that out at azkidsmd.com. Thanks so much for coming on today. I hope that people will respond and give us other ideas that they'd love to hear back from you, and we can have you back.
I would love it. If anyone has any good insights or has questions, I'm happy to.
Okay.
I'd love to come back. Thank you so much.
One of the best gifts you could give us at the Less Stress Life is your feedback. We are paid in podcast reviews. If you enjoyed this or any other episode, please leave us a review. In the iTunes store or from your podcast app, just search for Less Stress Life as if you're not already subscribed. Click on the banana face image, scroll to the bottom where it shows the text of other reviews, and write a review. While you're there, hey, make sure you hit subscribe. For Android or Stitcher users, you gotta go to the desktop site and search for Less Stress Life, and then scroll down to leave a review. Stitcher doesn't load Apple reviews on their site, so if you want, you can leave a review in both places. Your feedback means a lot to the success of the show. Thanks so much for taking the time to do that. You rock.